So everyone see the example of some extinction and inattention there? He slammed his arm in the car, probably having some loss of dull versus sharp, I like to say, maybe just a little bit. So if we were going to do an abbreviated NIH stroke scale, we can't do a whole lot with the level of consciousness, except for maybe, what, is he alert? Is he sleepy? He's alert, right? So he scores a 0 for that. Following commands, don't get in the car. But let's talk about motor. So on his right arm, what would you give him for a motor? Would be a 0, be a 1, 0, right? So he has full use. Okay, what about his left arm? 3, he's got nothing, right? Okay, and what about right leg? 3. So the right leg is the one he was using to drag, right? So that'd be a 0.
Oh,
and then the left leg, also a 3. He was kind of dragging that one along. All right. Perfect. So role of EMS, when I teach my EMTs, I ask them to remember to at least ask for the onset of symptoms or time last seen normal, and to bring someone with them that can confirm. Why is it so important that we know when the last time we saw them normal was? So if we are within the window and they meet the criterion, we can give medication. Very good. I ask, do not delay, because time is brain. All right. Ask them to get a finger stick blood sugar. Why? Because hypoglycemia can cause some of these impaired mental status. Ask them for 2 IV accesses, with one of which being an 18 gauge in the forearm, get an EKG, monitor neurologic functioning, and to provide supportive care. So the difference between a primary stroke center and a comprehensive stroke center. So primary stroke center is that we have a dedicated stroke-focused program. We're staffed by qualified medical professionals trained in stroke care. And we have individualized care to meet stroke patients' needs. Patients are involved in their hospital care, and we are collecting all of this information. So we do this at UVA. So we're looking at our goals, how quickly are we getting them to scanner, and we're using it to improve outcomes. Comprehensive Stroke Center has everything on this side of the slide plus the availability of MRI, CTA, basically big imaging. They have a neurosurgeon on 24 hours a day, as well as vascular neurology and endovascular radiologists. They have 24/7 availability of these people. They have ICU and neuroscience ICU facilities and capabilities. And they have experience and expertise treating patients with large ischemic strokes, ICHs, and subarachnoid hemorrhages. So these are the gold standards sent out by the American Heart Association. So door to doctor should be 10 minutes or less. Door to neurologic expertise should be 15 to 25 minutes. Door to CT scan, 25 minutes. Door to CT scan interpretation, 45, and this is all like this time and less. Door to treatment within 60 minutes. Onset of symptoms to administration of fibrinolytic therapies should be less than 3 to 4.5 hours. And door to admission within 3 hours. So the different things that we do for people with ischemic strokes versus hemorrhagic strokes. In an ischemic stroke, we're going to assess whether or not they're a candidate for fibrinolytics. If they're not a candidate, we're going to start with aspirin. So we're going to allow these people to be permissively hypertensive. So if we're giving fibrinolytics, it's going to be less than a systolic of 185 and a diastolic of 110. If we're not giving fibrinolytics, we're going to allow them to have a blood pressure of up to 220 systolic. Why do you think that is? It's to help with perfusion. So they have this insult to the brain where they're not getting enough nutrients, from not getting that blood flow. So we're going to allow their blood pressure to be a little bit higher so that we can get those nutrients and that blood flow to those areas of the brain that were deprived. Why do you think it's lower with fibrinolytic therapy than it is without? Because we have that increased risk of bleeding. Very good. We're going to get an EKG, we're going to get labs, we're going to get a finger stick blood sugar, if we haven't already, IV access, and a Foley catheter if not already completed. Why are we going to give a Foley catheter, especially right before we give fibrinolytics? Right, there are no invasive procedures after fibrinolytics. So if my person's neurologic status decreases, if they were already incontinent and have a neurogenic bladder, I can't do anything once I give fibrinolytics. So try to get that order early. We'll be doing neurologic monitoring and having supportive care, as well as speech therapy. So people are NPO until they're seen by a speech therapist. You have a question?
How long after you give the fibrinolytics before you can do invasive procedures?
Several hours.
24.
For an hemorrhagic stroke, we're going to keep tight blood pressure control. Their systolic blood pressure is going to be between 140 and 160. We'll do that through nicardipine or labetalol. We're going to talk whether or not they're a candidate for surgical management, whether that be through a coiling, so they'll actually go in through the groin and they'll put these wires up through where there was a rupture, and they'll seal off the area that way, or they'll actually go in more invasively and they'll clip the open area, or they'll do a craniotomy for an ICH. Again, we're going to get an EKG, labs, finger stick blood sugar. We're going to make sure they have IV access and Foley catheter. Again, supportive therapy, neurologic monitoring, and speech therapy. Fibrinolytics. So RTPA is recombinant tissue plasminogen activator. This is your thrombolytic or clot busting drug. There are a whole lot of inclusion criteria. So there has to be an ischemic stroke with neurologic deficit. Symptom onset is less than 3 to 4.5 hours, depending on what criterion they meet. If they're over 85, they don't meet that 4.5 hour mark, and they need to be at least 18 years old. There's a whole lot of exclusion criteria, like if they've had surgery, very recently if they've had a GI bleed. There are a whole lot, and actually if you look in your ACLS book, there is a list of exclusion criteria that I'll have you guys refer to. Actually, I'll pass that stuff around right there. I brought it with me. Once we give fibrinolytics, we'll be doing the abbreviated